I suppose I've got a relatively straightforward talk in terms of saying why do I think HCC surveillance needs to be improved and give the clinical perspective. And what do I want? Well, I suppose it's very straightforward. We want to have a higher proportion of patients who we see who have potentially curative disease. And so I could potentially end the talk there. So looking at the future, where would we like to be? Well, the NHS have a long-term plan, and what they have actually described is they want 75% of patients to have potentially curable disease detected by 2028. So that's where we want to be, and also to address things like inequality, variation in terms of patient outcomes, improve the experience that patients have. So that's where we want to be, but actually where are we at the moment? Well, below we sort of see a little audit we did in Liverpool, just looking at 500 patients. 25% of our patients in surveillance died while in a surveillance program, the majority of these within 2 years. 8% developed HCC over the proportion we were studying the patients. We also asked people to sort of look at alcohol consumption comorbidities, and it was deemed that 46% of our patients on our surveillance programs were not candidates for liver transplantation based on age or other clinical criteria. So it suggests that patient selection is an issue. So 75% by 2028, that's where we'd like to be. Where are we? I'm not sure how well this projects, but this is work from Vinay, who's sitting in the front row here, and Anya Burton, looking at patient outcomes and people being offered potentially curative treatment. At best, 21.4% of patients receive potentially curative treatment. 75% in 4 years. 21% at the moment. And some areas are even worse than that. So some centres do less than 16% have potentially curative disease or get offered a curative treatment. And no region gives more than 30%. So we really need to improve what we're doing at the moment. I suppose the other question I've asked myself is, what is the purpose of surveillance and what are we trying to achieve in the 21st century? Is it just about case capture? Or is it about identifying patients who are amenable to receive potential curative treatment? What is curative treatment? I know there may be some people in the room who think that the only true curative treatment is liver transplantation. I can see Phil Johnson nodding his head. Other people may say, well, there are other potentially curative treatments such as ablation, resection. So another little fudge we made in the past was sort of saying in our region, well, if you're fit for a general anaesthetic, we might enroll you into HCC surveillance. And if you're not fit for a general anaesthetic, you can't have an ablation, therefore you're not fit for anything. But now you've got SBRT, you've got CERT, you don't need a general anaesthetic. What do we do? So what is cure? 5-year survival? Restoration of normal life expectancy to the region in which you live? I don't know. So what should the clinician think about when enrolling someone into HCC surveillance? And these are sort of the factors running through my head. What is the patient's risk of developing HCC, and over what time period? And how often should I reassess that? What is their risk of dying from their underlying liver disease? What is their risk of dying from non-related liver disease? You know, some of these people have lived, some of our patients have lived pretty crazy lifestyles and have underlying cardiac problems, respiratory problems. Would they benefit from their treatment for HCC? We can sometimes do the wrong thing for the right reasons and actually shorten life expectancy rather than prolong it. And if I do give them treatment, how do I know that they've benefited? So this is what we need. This is a picture of me in clinic in about 5 years' time when I've decided to grow my hair and grow my beard. And I've got my sort of little crystal ball, my stats machine. We need to be able to balance all these competing interests and difficulties and be able to work out what is it that would be best for the patient sitting in front of me. Because often when you're talking about surveillance, you're talking about population-based issues. But actually for the patient in front of you, they're not worried about that. They want to know what their risk is, what their benefits would be from surveillance. So this is, as Tom has just alluded to, this is where we stand at the moment. All patients deemed to be at high risk of developing hepatocellular carcinoma will be offered 6-monthly surveillance with ultrasound. That's pretty broad, isn't it? So does one size fit all? And I suspect this is going to come on to a little bit later. What about the impacts of age, gender, etiology, smoking, other comorbidities? How do we balance those in terms of what, again, is best for the patient. So what might be easy to deliver and administer may actually not be best for the patient sitting in front of us. And how do we navigate that? In addition, we live in a resource-scarce environment. That 75% applies to all cancers, not just liver cancer. So for the radiologists in the room, they know what it's like. All clinicians are saying we want dedicated slots for our speciality, for our patients. So we don't want to, disadvantage other patients through just what we want to do. We want to do what's best for all patients. So sort of very much a utilitarian approach to patients and how we deliver things. I'm not sure how this projects very well, but it's just sort of highlights some of the issues with surveillance. In short, this is data from the Royal Liverpool with an automated surveillance program between 2009 and 2016, and we just audited our outcomes for patients in surveillance. 804 patients, about 30-40% dropped out after 2 years for a variety of reasons. Just under half completed surveillance, 81 had suspicious lesions. 31 had lesions which looked suspicious for HCC. 19 were deemed to be radiologically curative. 16 patients were assessed for curative treatment. 9 were assessed for transplant, 5 were listed for transplant. But at the end, we had 1 resection, 9 RFAs, and 1 transplant. That's a lot of resource. So we know that we need to identify the right patients at the right time and give them the right treatment. But doing ad hoc, everybody all included, that's not a good use of resource, and it's probably not good for patients either. So I think we definitely need to improve surveillance. Early diagnosis is the key to good outcomes. And I suspect, and this is a nod to Pam here really, that earlier diagnosis of advanced liver disease and cirrhosis is probably going to be the key. We're not going to address that today, but that is a fact which is very, very important. If we don't flush those out, we're not going to get the benefits further downstream. We do have a defined population, so it's easier than other certain cancer screening programs. What we do with the MASL patients is a bit more problematic, but I'm hoping we're going to get some answers on that today. We need to define our goals. What are we trying to achieve from surveillance? Who benefits, who doesn't? How should we look at enrolment and unenrolment? Does one size fit all? Having a national registry so we can actually look nationally at all patients, not just regionally, will be a massive gain in terms of what we achieve, and I think Mukti may touch on that. So in short, we need to improve surveillance and do better for our patients. We need to aim for 75%. I'm not sure we're going to get there, but it's certainly a target to aim for. And really, I don't have answers, but lots of questions. Thank you.